I just wanted to welcome everyone again. I'm Andrew Chang. I'm one of the general thoracic surgeons at University of Michigan, and this is our open house. I'm the associate program director, and we're really happy to see the number of people that have signed on. Hopefully none of you are Zoom bombers, but if you are, we'll know how to take care of you. So, but otherwise, feel free to raise a hand, ask questions during the presentations. It's much as possible. We want to make this interactive. So anything you can do to make it a two-way conversation would be fine. We're going to start off with the presentations from, I just have a few more minutes of introductory comments, and then Dr. Fukuhara, who's our program director, will talk, give you some insight about the program. And then our chief, Dr. Sarah Palmer, will provide her perspective as a senior resident, as a chief. And then Dr. Alawadi, the Department of Cardiac Surgery chair, will provide his vision for the program. And that'll take about half an hour, 40 minutes or so. Around 7:40, the plan is that we'll have 3 separate breakout rooms. You'll each, through the magic of Karen Bowering, who is our program coordinator, she's going to assign you to each of the rooms. One is going to be an adult cardiac, one will be general thoracic, and then the third will be congenital cardiac. And each of you, each flight will have 10 minutes in each room. And we have Dr. Himanshu Patel, who will give a brief introduction to the adult cardiac program. Dr. Jenna Romano will talk about the congenital cardiac program. And then Dr. Karen Lagisetty will talk about our general thoracic program. And then there should be time for questions. And then at the end of 10 minutes, Karen will automatically flip you into the next room. So you'll all get a chance to circulate through the 3 rooms. And then we'll hopefully have a few minutes at the end for some last minute questions. And hopefully that will give you at least a taste of what our program is about. I think just in the next few minutes, I don't have any slides, but what our program, I think, has a lot of history. The thoracic surgery residency was started in the U.S. Back in the late 1920s by John Alexander, who was a professor of thoracic surgery at that point. So just so you understand sort of the nomenclature, thoracic surgery, meaning the big capital T thoracic, encompasses the 3 areas that you'll hear about today: adult cardiac, congenital cardiac, and general thoracic. There are all sorts of different names, but the RRC, ACGME really calls it a thoracic surgery residency, which is why we tweeted that thing out just to specify. But so thoracic surgery started out really surgery for tuberculosis. There really wasn't much else we could do at the time. There's no such thing as open heart surgery in the late 1920s, but people were dying left and right of tuberculosis. And Dr. Alexander realized that the way surgery trainees were being taught, specifically thoracic surgery, was not safe for patients. And so he instituted a program of stepwise graduated responsibility similar to the Halsted program for all of surgery, and he adapted that. And that's been in place since the 1920s. In 2013, we really in the late 2000s, we realized that there should be another avenue for students to go from medical school into thoracic surgery. And that's really where the integrated program began. There were fits and starts for integrated programs, even in the 60s and 70s. And even where I went to medical school, there was essentially an integrated program or a 4-3 program, even as late as when did I graduate? Oh my God, in the 1990s. But that went away. But then we felt the need to start the integrated program again. And so in 2013, we received approval from the ACGME to implement this program. And so we've been in existence now for 8 years. Dr. Palmer will be our 3rd graduate, but she was our first resident. And in the first few years, we had a mandatory 6, but then when you think about it, 6 years is a long time to do straight training. And we implemented a 2-year research time, which falls between the 3rd and 4th year. And so even though we've been in place for 8 years, it's still relatively young. And I think you'll hear from the faculty and the residents today a little bit more about how the program's evolved over the last few years and where we hope to go. And so with that, I'm going to transition things over to Dr. Fukuhara, and he'll tell you a little bit about his thoughts regarding the residency program. So thanks again for joining us, and I'll see you in the general thoracic room in a little bit.
Thank you so much, Andrew, for the introduction. Let me share my screen. I think this. Okay, can everyone see this?
Yes.
I hope I can control this on my end. Slideshow. So you can see it now, right?
Looks great. Yep.
Yes.
Okay, yeah. So good evening, everyone. My name is Shinichi Fukuhara. It's been 3 years since I joined the University of Michigan Department of Cardiac Surgery, and I am starting my new role, which is the program director of our CT surgery residency. Thank you so much for your time joining this event, and I'm really hoping this event is helpful. For the next 10 minutes or so, I'd like to talk about why I think the University of Michigan CT surgery residency program is the best. This is a sort of a perspective from experience at the 4 major academic institutions I worked for in the past. So I am originally from Tokyo, Japan, and moved to the United States in 2010. I have worked at the Mount Sinai, Columbia in New York, UPenn, Philadelphia, and the Cleveland Clinic before joining University of Michigan program. Therefore, I have worked at a variety of different major CT surgery programs. From this unique experience, I can share my honest opinion why University of Michigan is the best. Okay, before I start, I'd like to emphasize this. Every residency program you attend or interview, everyone without exceptions talks about how excellent their clinical volume, academic experience, how great their didactics, simulation labs, mock oral exam, something like that. I wouldn't go over these things in my talk, as we also have everything here. For instance, if you go to websites of other CT surgery residency programs, you always see our residents easily get the ACGMA minimal case number for board certification before the last year of training. This is nothing special. We do those, and all other programs do those as well. However, what distinguishes Michigan program from others is that all services you work with are equally one of the best in the country. For example, some programs have outstanding adult cardiac surgery clinical volume, while their congenital program is very weak. Some programs have great subspecialty services such as aortic, such as robotic, but their general thoracic surgery rotation is weak. At the University of Michigan, there is no such thing. All services are equally super strong, including general surgery and the vascular surgery services where our residents rotate. Our program has a strong academic background. As some of you know, our department is one of the top funded CT surgery groups in the country. There were some other top funded programs, but they are not necessarily strong clinically. University of Michigan truly has both academic and clinical background. I asked one of our residents publication list at the University of Michigan, who is currently in 5th clinical year, finished a 2-year research period. I was unable to squeeze his list despite using the smallest font. He has published almost 70 papers during his residency, and he hasn't even finished yet. Our residents present at the national and international meetings. Of course, other programs also provide such excellent research experience. However, I can tell you our residents here are the most productive compared with those in other residency programs I previously worked for. Our residency training involves a variety of unique subspecialties in CT surgery. For example, our aortic surgery service has 4 dedicated aortic surgeons from different training backgrounds: Michigan, Stanford, UPenn, and Columbia. Our type A dissection case volume is the top 3 in the nation. We are one of the few cardiac surgery programs that perform T-bars. Additionally, there are tons of valve sparing root, Ross, complex arch, complex thoracoabdominal aortic repairs. There are a number of programs that offer some good, like a Deeb procedure experience, but they don't necessarily have many type A dissection experience, or there's no T-bar experience or no open thoracic repairs. This is the only one of few programs that has a complete list of all aortic procedures. In this photo, he is our most recent graduate. He called us a few days ago that his first case, which was a Deeb procedure, was successfully performed. When we hear such good news, this is the most exciting moment for us. What kind of a new graduate perform a Deeb procedure as the first case after graduation? And the example 2, general thoracic surgery. I just captured the Twitter page of another our recent graduate. This was her typical week. She has experienced more than 50 lung transplants while she was here. She also performed a fair number of cardiac surgery cases as the primary surgeon, despite being in the thoracic surgery track. I don't think other programs produce what she experienced here. And we truly value work-life balance as a residency program. Work-life balance means different things to different people. I personally think true work-life balance comes from happiness, not the actual work hours. Happiness is associated with the satisfaction with the training. Among the programs I worked in the past, not many other programs take this as seriously as our program. We take immense pride in teaching residents. Our aim is to make our trainees #1 in the country and become national leaders in each field in the future. We are very ambitious about this goal, and then I want our candidates to be as ambitious as we are. Thank you so much for your time, and I hope to have a chance to meet with you and answer some questions soon. Thank you so much.
All right, Karen, would you like me to share my screen?
Yep.
All right.
Dr. Sarah Palmer.
All right, can you see that?
Yeah.
So my name is Sarah. As Dr. Chang mentioned, I interviewed at Michigan over 8 or 9 years ago, and I was in the first class of the integrated program. My co-resident, Vic, didn't do 2 years of research. He went straight through, and he's now congenital faculty here at Michigan. I just want to say welcome again to all the potential applicants. And I remember being kind of where you are and how exciting of a time this is in medical school, but also how stressful it can be. And so please, at the end of this, whatever questions you have, we're happy to answer. A disclaimer, I can only give you my experience. I know that most of, actually, all of our residents are very happy here. This is kind of my story, and you'll see some of the same photos too, but I just wanted to go over, I started back in 2013, and the first 3 years were mostly 50% general surgery and 50% cardiothoracic. I think we're evolving to do more and more CT and a little bit less general surgery, but I don't think the general surgery time is a bad thing. I loved the time that we had. As Dr. Fukuhara said, the Gen Surg program here is phenomenal. I think they're ranked #1 currently, and they treat us like they do their own residence. We learn a lot from them about how to be doctors, how to be clinicians, how to know what's going on kind of below the diaphragm. So, we really value the time that we spend with them. A lot of us, our close friends, are actually in the general surgery department, the vascular surgery department. So that I think is a big plus. And then I did take 2 years to do academic development time. It was optional at that time, but now it's built into the program. I did do 2 years to do a master's in clinical research. I also used that time to get married and have my first baby, which you'll see a lot of pictures of. And then I came back as a 4. And the last 3 years are mostly cardiothoracic training. So here I put there's 2 months as trauma chief on general surgery. Again, that was a great experience. You get to run traumas, you get to manage a team of 50, patients with, interns and mid-levels and NPs and PAs. And it's a phenomenal learning experience. It really, helped me to grow as a leader. But that's kind of the last you ever go to general surgery. And then you do 2 months of congenital over at Mott. For those of you that are interested in congenital, there's always the option to do more. My co-resident Vic, he finagled a lot of congenital in his last year. So it's pretty variable depending on your interest. But again, the last 3 years are mostly cardiothoracic surgery. So I thought I would just show a sample month. This is last month, and it's a typical month. And let's see, I counted it up. I think there were 27 cases. As you can tell, Thursday is a clinic day, so there's not many cases there. But this month was 4 CABGs, 5 valves. But I also want to draw your attention, there are several redo operations, several Bentals, and even at the last week, there were 2 valve sparing routes in a row. And as Dr. Fukuhara mentioned, we really specialize in these kind of complex cases. And I don't think there's any other training program where the trainee would get to do 2 valve sparing routes, back to back like that. And again, everywhere that you see a star is the case that I consider that I can log that I did from the surgeon side, from the right side of the table. And so this is, again, 27 cases in 1 month averages to over 300 a year, which is about right, because my chief year, I think I did 331 cases. And again, it's really hard work, but it's super fun. And if you look at the calendar, just by chance, you'll see that there is a couple of non-operative things that I wanted to point out. So like on the 1st, there's this resident talk, and actually the faculty and Dr. Alawadi asked the residents to present our vision for the department. And so we had the opportunity to do that and to share with our faculty kind of our goals and kind of what we envisioned. And I don't think there's a lot of programs that would really value input at that level and kind of, spend a whole morning with all the faculty to just hear from us and our point of view. So that is, I think, a key thing there. You'll see on the 11th, there's this wedding that was one of our residents got married. So we got to go and do that. On the 17th, we had an end of the year party. So that was at Dr. Half's house, which I have a photo of. And then again, graduation was on Sunday on the 25th. But I stayed on, and I'm currently going to do another year as the aortic fellow, which is why I'm still here and I'm talking to you all. I wanted to mention life events. So I did get married during residency. I started residency very single, so it is possible. And then I also had 2 babies. This one is Abigail. This one is Amelia. We baby 1 and baby 2. They're pretty close together, but I brought this up because, it's very welcome in our department to start your own family, to have children. From a female perspective, I had no difficulty whatsoever. And this might be a little TMI, like I didn't breastfeed, but a lot of my co-residents got pregnant, they had babies, they take pumping breaks. That is very normalized in our department. It's not weird, and everyone is used to it. So it is very family friendly, female friendly. And again, I had to put my pictures of my babies in here. Here they are. They're bigger now. They're 2 and 3. And this is at the Arboretum, which is behind our hospital. So behind Mott's Children's Hospital is a huge kind of arboretum, which I didn't even know what that meant until I came to Ann Arbor, but apparently trees are very big here. And there's peony gardens and trails, and there's a river. And it's nice to be able to take a break, walk out back there, but also my kids and family come to see me when I'm on call, and it's just a really nice thing to be able to bring your kids to work. I wanted to include this because, as I mentioned, we are about 50% male, 50% female at this point. This is a picture not from the New York Times. This is us. So this is Tessa. She's our chief resident here. This is me. I think Candace is in here. Kellyanne is in here. But again, you know, we are really proud of the fact that we try to be very inclusive here. You already saw some of these photos. This is a thumbs up after a heart transplant that I got to do with Dr. Haft. Again, I didn't put in that list because I wasn't on transplant in July, but I think I did 12 this year, which is a lot for any trainee. This is our beer pong tournament. I don't know if I'm allowed to say this, but every year we have a beer pong tournament. We didn't last year. In the background, I want you to notice this is the very infamous pole barn that one of our residents owns, and we have a lot of our events in the pole barn. So if you come, we'll have a lot of fun and a lot of events, hopefully, once this COVID is over. We do a lot of outside the hospital activities. So this is Alex Brescia. I don't know how he published 70 papers because we do a lot of events and go out a lot. So it's quite impressive. But again, we try and have fun when we can. This is the wellness event. You'll see not just my 2 babies, but here's Alex holding his first. Here's Katie holding hers, and then Tessa's trying. She's really trying hard, but Lily would not cooperate. Tessa, she's our current chief, and she is expecting her second baby. So again, it is pretty awesome to see that. And then this picture is from our roast, which we just had of the chiefs. This is Habib, who just graduated. He was the last aortic fellow that Dr. Fukuhara mentioned. He did do a valve sparing route as his first case as an attending, which is very impressive. And again, Caitlin on my other side is starting at Vanderbilt as faculty. And, you know, I talked a lot about cardiac and all the cardiac stuff, but I can't speak highly enough of the thoracic program here. Caitlin did more lung transplants than anyone I've ever heard of, which is great. I mean, over 50 is a ton. I think some of our faculty who trained at other institutions maybe did 40, maybe, and that was considered good. So I just thought it was really awesome to see her get such a nice job too, out the gate. And I think that's all I have. So again, if you all have any questions whatsoever, we'll provide all of our email addresses if you want to just email me, or you can follow us on Twitter. I think I should have included those hashtags, but we really like it here. I love it here. I wouldn't change my decision ever. And you know, there's a reason Vic stayed. There's a reason I want to stay. We really like not just the job and the cases, but the people here. And I'm a little sad that this can't be in person, because I remember, you know, coming to Michigan and really thinking, wow, that place is special. So hopefully it comes across through the screen. But again, we really love it here, and we would want people who fit in and who love this place too.
Thanks, Sarah. And to wrap up this introduction, we're going to ask Dr. Alawati to describe your vision. So Gaurav, all yours.
Great. And thank you all for joining. I apologize, I was a few minutes late due to a conflicting call. And let me know if you can see, which slide do you see? Do you see the
introduction
slide?
Yeah, we see
Your
the
introduction.
preview
Vision
window.
of CT surgery.
Right. And is it a presenter slide?
Yes.
Yeah,
I don't know how to change that. Let's see.
yeah, I know.
All right. How's that?
That's better.
Yeah.
Okay, all right. So welcome again, and I'll try not to be duplicative with all the great knowledge that you've learned. And Sarah, that was a fantastic talk. So thanks for sharing your heart with everybody. And it's been a real pleasure to get to know you and train you. So you've already heard this from Dr. Fukuhara. Our goal at Michigan is to train the future leaders in CT surgery. That's really quite simply our goal. There are some additional goals, and I think you'll see that from the talks that you've heard, and that's really to provide really an unparalleled experience, both in the operating room, in the perioperative care of the patient, pre-op, post-op, as well as in research and leadership opportunities. You've seen that we're trying to create a family environment between attendings and residents. That's, nowadays, we think really important. You come and spend almost a decade of your life with us. Many of you have families that are, come into life and are raised while you're a part of our family. And so that's important to us. And then really importantly is really committed to getting our trainees the best jobs available. And it's a pretty deep bench of faculty, of thoracic, congenital, and adult heart surgeons that know a lot of people across the country. And we want our trainees to be the ones that are called for all the best jobs. And that's what you would expect at a program like Michigan. We try to mentor all aspects of surgery. On the clinical side, there's not just the clinical skills and the judgment skills and technical skills, but there's also a lot of knowledge, and I'll talk about that as well. Research side, there's a lot to learn, not just how to write a paper, how to present, but how to ask good clinical questions. And then on the professional side, presenting at national meetings, there's lots of our residents that have societal and committee roles. We've had the president of the TSRA. We've got a number of residents in various leadership positions that really get propagated, I think, because of the brand of Michigan. In terms of the clinical experience, I'm not going to go into a lot of detail. I know Dr. Chang likely presented you more details, but we are a large program and we're growing. We're actually building a new hospital tower where more than half the footprint will be CT surgery. So an additional 100 plus beds will be dedicated for CT surgery. And you can expect that would be done in about 4 years. So 3 years into your training, and that will allow us to grow. Our goal in the operating room is that every case is performed with a resident or fellow, and they're standing on the right side. We have so many cases right now, even before the addition of the new hospital, that oftentimes only half the cases do we have a resident in the OR. So many of the faculty then are operating with a PA, and that's not our goal. We want to grow our program so that we have enough trainees that they can enjoy and learn from every single case, and they're not missing out. I know some of our residents, and Sarah can probably attest to this, they're torn. They've got choices between different cases. They'd love to do it all, particularly a valve sparing route next to another valve sparing route. How do you choose? You want to do both, and you can't always do that. So we want to use each case as a learning opportunity. Our goal is the residents are really integral in the case, making the plan of the operative approach with the attending the night before, sending a plan and a huddle to the entire OR team about what we're planning to do. And our trainees then round and cover their patients all the way through discharge. So again, they're really integral in the preoperative assessment and the planning and the postoperative care. There are many times our residents pick up things on the pre-op assessment the night before that may not have been captured. A typical resident in the OR will experience all of our attendings, and this is just obviously a small snapshot. You notice that they're standing on the right side, and these are all complex cases, and you've heard that already. And again, we have more residents than what the ORs can cover. Here's just an example. We have 5 ORs running, 5 cardiac ORs running, and only 2 on this particular day were covered with residents. So again, an opportunity for growth. We also try to teach more than just the technical aspects. CT surgery is a lot more than that, and we have a lot of didactic conferences. And hopefully, when you visit virtually, You'll learn a lot more. Virtually every day there's a conference, an educational conference. We do follow the STS ebook as well throughout a 2-year course. And we're very proud, really very proud that our residents won the International Jeopardy competition. So I think they beat a group from Germany. So really fantastic, and make us very proud that they've learned that much. There's probably a lot more than we can talk about research, but I do want to emphasize there's a deep bench of lots of different types of research that goes on, from translational research to health services, outcomes research, clinical trials. We have more clinical trials than you can probably count. I mean, it's probably 50 different clinical trials going on in our department in cardiology that we're working with, and residents get to be very much involved with the newest technologies that are out there. And there's also opportunities for innovation. We have some residents that have patents that have developed new ideas. We have a number of our faculty that have developed companies that residents are learning from. We have a lot of funding in our department. I would argue we probably are the #1 funded group of cardiac surgeons in the nation, with lots of NIH funding. And residents spend during their time in academic time over their 2 years. Oftentimes they're presenting at national meetings and have a lot of publications. Most of them exceed 20 publications. Some have quite a few more. You've heard Dr. Brescia has, I think, over 70. And our goal is that at every major meeting, our residents are presenting at ATS, STS, STSA, and the list goes on and on. So to summarize, we have more cases than are covered by trainees, so there's plenty of opportunity to learn, and nobody's stepping on each other's toes. We are a premier health system. Both U.S. News and Newsweek were highly rated. You heard the general surgery program that we have very, very close ties with their leadership as well. They're the top rated program from Doximity. The volume and complexity at Michigan is really second to none across all the subspecialties within CT surgery, including thoracic and congenital, and the subspecialties within adult cardiac surgery. And the residents are really integral to the care of the patient. So thank you. I know there's going to be opportunities in the breakout sessions to learn about our program more. And again, I want to welcome you. Thank you.